Next, we will discuss bowel atresia or obstruction, a congenital condition affecting gastrointestinal tract. Bowel atresia occurs when there is a complete or partial blockage of the intestinal lumen, preventing the normal passage of amniotic fluid and fetal bowel contents. This anomaly can occur anywhere in the gastrointestinal tract, but it most commonly affects the small intestine, specifically the duodenum or ileum. Early detection through prenatal ultrasound is essential for planning appropriate perinatal care and postnatal surgical intervention. Types of bowel atresia, each affecting specific regions of the gastrointestinal tract. Jejunoileal atresia, where there is a blockage in the duodenum. It is characterized by the classic double bubble sign on ultrasound. It is often associated with trisomy 21 and other congenital anomalies. Jejunoileal atresia affects the jejunum or ileum and is the most common form of small bowel atresia. It typically results from vascular disruptions during fetal development. They can lead to dilated loops of bowel and polyhydramnios on ultrasound. Colonic atresia is rare form of atresia that involves the large intestine, less frequently diagnosed prenatally, but can present with abdominal distension and delayed passage of meconium after birth. Early detection of bowel atresia is crucial for appropriate tertiary planning and postnatal surgical management. Bowel atresia develops due to disruption in normal fetal intestinal development. There are two primary causes: incomplete recanalization of the bowel during early gestation. The fetal intestine temporarily becomes a solid organ before recanalizing it to a hollow tube. If this process is incomplete, a blockage or atresia can form. Vascular accidents, a disruption in fetal blood supply can lead to ischemia and necrosis of a bowel segment, resulting in atresia. This is particularly common in jejunoileal atresia. As a result, fluid accumulates proximal to the obstruction, leading to dilated bowel loops visible on ultrasound. The severity of dilatation depends on the level of obstruction and whether peristalsis is still present. Understanding the pathophysiology of atresia helps in predicting complications and planning for postnatal management. Ultrasound plays a crucial role in diagnosing bowel atresia or obstruction, and 3D and 4D imaging provide additional insights. 3D ultrasounds helps in visualizing the spatial arrangement of dilated bowel loops, offering a more detailed anatomical overview. This can assist in differentiating between different types of atresia and evaluating the extent of the obstruction. 4D ultrasound enables real-time assessment of bowel peristalsis. In cases of obstruction, peristalsis may be reduced or absent in the affected segment, helping to confirm the diagnosis. Together, these advanced imaging techniques enhance diagnostic accuracy and aid in prenatal counseling and postnatal planning. The ultrasound findings in bowel atresia or obstruction can provide crucial diagnostic clues. Our first finding can be dilated bowel loops, where there is fluid-filled loops seen proximal to the obstruction, indicating a blockage. Accompanying polyhydramnios, maybe late onset polyhydramnios, um, due to impaired swallowing, commonly seen in gastrointestinal obstructions, of course. Another finding can be the double bubble sign, a classic feature of duodenal atresia, showing a distended stomach and proximal duodenum on ultrasound. Absent or diminished peristalsis, real-time imaging may show decreased bowel movement, differentiating obstruction from other conditions. Echogenic bowel. Uh, the bowel may look bright, and this may indicate complications like meconium, peritonitis, or ischemia. Recognizing these features is key to early diagnosis and management planning. Atresia is often linked to other congenital conditions which can impact diagnosis and management. Duodenal atresia is strongly associated with Down syndrome, occurring in up to 30% of cases, and may also be linked to cardiac defects. Jejunoileal atresia can be related to cystic fibrosis or result from vascular disruptions during development, leading to ischemic bowel damage. Colonic atresia is rare but may be seen alongside anorectal malformations, requiring a comprehensive evaluation of the lower gastrointestinal tract. Understanding these associations helps guide further testing and prenatal counseling. When evaluating fetal bowel abnormalities, it is essential to differentiate bowel atresia from other conditions with similar ultrasound findings. Bowel atresia is characterized by progressive bowel dilatation, often with fluid accumulation proximal to the obstruction. In some cases, we may also observe echogenic bowel, particularly if the complication uh, like meconium peritonitis are present. Gastroschisis, on the other hand, is distinct because it involves free floating bowel loops outside the abdomen, directly exposed to the amniotic fluid without a covering membrane. Unlike bowel atresia, there is no intrinsic blockage. Rather, the bowel is vulnerable to inflammation and damage from prolonged exposure to amniotic fluid. Another important differential is Meconium ileus, which is linked to cystic fibrosis. This condition presents with the echogenic bowel, where thick meconium obstructs the intestines, leading to characteristic ultrasound findings. By carefully assessing bowel dilatation, echogenicity, and fluid patterns, we can differentiate these conditions and guide further evaluation and managing bowel atresia or obstruction begins with careful prenatal monitoring, where regular ultrasounds help assess the condition of the bowel, fetal growth, and amniotic fluid levels. In cases of duodenal atresia, karyotyping may be recommended due to its strong association with chromosomal abnormalities, particularly Down syndrome. When planning delivery, vaginal birth is often possible, but for optimal care, delivery at a tertiary care center with neonatal surgical expertise is advised. After birth, immediate nasogastric compression is performed to relieve pressure in the dilated bowel. Surgical repair follows with techniques such as bowel resection and anastomosis to restore normal function. The prognosis varies depending on the location and severity of the obstruction, as well as any associated abnormalities. In isolated cases, outcomes are excellent with timely surgical management. However, the presence of additional conditions may impact long-term recovery. Early diagnosis and appropriate intervention remain key to optimizing neonatal outcomes.